Good afternoon, everybody. So it's just turned 2 p.m. We've got quite a lot of content to cover off today. I can see that the numbers are still trickling up, but I think for the sake of time, because we've got so much content to get through, I'm going to propose that we kick things off at 2 p.m. sharp. So first and foremost, it's great to see so many of you tuning in for today's session. Let me just turn my camera on. Actually, I just realised that I've not done that. Yeah, thanks for tuning in for today's session, which we've called The Future of Healthcare, a new foundation for improving patient outcomes. So I hope that you're all comfortable. You managed to grab a tea and a coffee, and this promises to be a really exciting session. But I guess, before we dive into things and take a look at the future, I just wanted to take a moment really and acknowledge the past. We've just reached the momentous 75th anniversary of our NHS. So I just wanted to say a big thank you to the NHS. At Ezra UK, we stand alongside you and are extremely grateful for the opportunity to contribute towards your mission. Your unwavering commitment to provide high quality care to all tirelessly, even during the most challenging times, has saved countless lives and offered solace to those most in need. So from me and my team and the whole of Ezra UK, a very dear and sincere thank you to all of you in the NHS. So a couple of things just to kick off on housekeeping. So if I could please ask that all cameras and microphones remain off. This will just ensure that things run smoothly and to time. We are recording this webinar and we'll share a link with you afterwards. And please do share this with any of your colleagues that were unable to make today's session. Finally, we are answering questions at the end of the session. So to participate and contribute, we are doing this using Slido. So if you do want to ask questions and contribute, then you can access Slido either by scanning the QR code on the screen, or alternatively heading to slido.com and joining with hashtag Esri0508. So we are tight on time, so any questions that we don't answer today, we will answer them and distribute those answers to everybody in a follow-on email.
Sorry, Duncan, it is 0507.
Okay, 0507. Thank you, Donna. Yep. So a quick look at today's agenda, and as promised, we have an exciting session lined up for you all today. So I'll be kicking things off with an initial welcome, some context and background. And for those of you that do not know me, so my name is Duncan Booth and I am the Head of Health and Social Care at Ezra UK. I'll then be handing over to Adnan Burke and Josie Voss from NHS South Central West Commissioning Support Unit, who are going to present a case study and showcase the application that they have developed, which enables users to unlock location intelligence, providing the ability to benchmark and monitor bowel screening uptake at a localised level. And this was supporting the Sussex Integrated Care System. We'll then hear from Sally Cox and Daniel Cullen from Digital Health and Care Wales, and they are going to showcase their Health Maps Wales application, which makes sense of statistical data in a spatial context, helping identify trends over time, forecast future demand, and describe how they've used this tool to visualise and interpret data variations throughout Wales. Last, but by no means least, we'll then be hearing from Robert Sinfield, who joins us from NHS North East London Integrated Care Board, who is going to showcase the novel way in which he is using Esri technology to understand and segment the population within his community, understand service accessibility, and the work he is leading on to measure spatial statistics over time and identify exactly where things are happening. And this is driving changes to their approach to population health management. We'll then move on to our Q&A session, and our speakers will pick up any questions that you have. Now, I am aware that we have many people on this webinar who may not know exactly who Esri UK are. So really briefly, I did just want to provide some context. So our motto is the science of where, and we are passionate about helping organisations extract the maximum value from their data by understanding it through the lens of geography. And we are the global leaders in this space. So it is worth noting that we do work beyond health and social care. So globally, we have around 350,000 customers, and these come from government, defence, and even the commercial world and utilities as well. That said, we do work extensively throughout health and social care. So globally, we work with organisations such as the World Health Organization. Nationally, within the UK, we work with the Department of Health and Social Care, Public Health Scotland, and the UK's Health Security Agency. But we also work with numerous integrated care boards and NHS trusts as well. And we are extremely proud to annually reinvest over 30% of our revenues directly back into R&D, which really ensures that our technology continues to improve and delivers the best possible value for our clients. But why is this of interest to you all today? Well, geography unites us, but more importantly, it unifies and connects data. Everything happens somewhere and at some point in time. Esri technology is far more than looking at points on a map. Instead, it provides a unique capability which integrates disparate and seemingly unconnected data sets and unifies them through the power of geography. It empowers us to create digital twins, and by creating these digital twins, we can enhance our understanding of the world and our communities, unlocking new and novel location intelligence. For example, we can better understand the wider determinants of health and how they are influencing health outcomes. We can truly improve our understanding of the accessibility to services. We can understand and forecast service demand, and we can identify relationships between wider factors and disease prevalence. For example, air pollution and asthma, or certain cancers. This derived location intelligence will enable decision makers to make informed, evidence-based, and proactive decisions and move away from being reactive to become preventative, releasing the burden on our healthcare system, helping us reduce health inequalities, and of course, saving money for our ever-stretched NHS. And this is why location intelligence really is a non-negotiable as we consider the healthcare system of the future. So location intelligence really does uniquely contribute to any population health management strategy. So I'm now delighted to hand over to Adam and Josie, and they're going to showcase how they are leveraging Esri technology to benchmark, monitor, and improve bowel cancer screening across Sussex. Adam, over to you.
Thanks, Duncan. And Josie's going to share a screen. Thank you, Josie. So thank you for the introduction, Duncan. Our geospatial team at South Central and West Commission Support Unit work within the NHS using the ArcGIS system to solve complex geospatial problems. And this afternoon, we're going to talk you through one of those complex health GIS problems as an example of our work and how we're using GIS and spatial data to improve patient outcomes. So as I said, my name's Adam Burke, and I've worked at South Central and West for almost 12 months now as Associate Head of Geospatial Services. My role involves supporting a geospatial service across a busy, complex NHS function. Our team is the largest geospatial service across any of England's NHS regions and integrated care boards. We're a team of 22 geospatial professionals comprising of geospatial analysts, senior geospatial analysts, and principal geospatial analysts. So who do we work with and what do we do? We support 20 integrated care boards, or ICBs, across the south of England, plus 3 regional NHS teams, South West, South East, and the Midlands. We also support NHS England centrally around projects such as screening and immunisation, dental and pharmacy commissioning, and provide GIS services to several NHS hospital trusts. Our work helps integrated care boards and their populations through areas such as effective primary care management and development, workforce and estates, population health management, health inequalities, service transformation, travel time analysis, and the green agenda and carbon net zero. Today, I'm presenting alongside my colleague Josie Vaz, who will also introduce herself. Josie.
Thanks, Adam. Yeah, hi everyone. My name's Josie Voss. I'm one of the senior geospatial analysts on the team. So I've been at STW now for over 3 years with involvement across lots of different geospatial products which have been built using Esri technologies. So I'm going to be walking you through a quick demonstration of one of these projects today, which focuses on bowel cancer screening. So back to you, Adam, for some context around this project.
Thanks, Josie. So I want to introduce the bespoke geospatial web application that we've created using ArcGIS Enterprise. This has been developed to provide insights into screening uptake and health inequalities within bowel cancer screening programme within the Sussex region. First off, a bit of context around the development of this tool so you can understand the need for it and the important role it plays in improving patient outcomes. Bowel cancer is the 4th most common cancer in the UK and the 2nd biggest cancer killer, with nearly 43,000 people diagnosed with bowel cancer every year in the UK. However, bowel cancer is treatable and curable, especially if diagnosed early. Nearly everyone who survives bowel cancer, if diagnosed at the earliest stage. However, the challenge is acquiring detailed bowel cancer screening data at localised levels. This has always been a challenge in the primary care environment. Working with regional hubs and integrated care systems, we can access acute local level data as well as specific population demographic level data to enable early identification. I'll now hand over to Josie to talk through the application in more detail.
So to address this challenge, we've developed several online solutions using ArcGIS, and we've produced one bespoke application for each geography. So that's GP practice level, primary care network level, so PCN level, and lower super output area level, LSOA level. So I'm going to play a video for you now just to walk us through those 3 applications. Do let me know if the video doesn't seem to be playing, and I'll happily take any questions about these applications at the end of the session. So we begin by opening up the project to a landing page. This is actually an ArcGIS dashboard, and this hosts the 3 applications for the different geographies. So within here, we've got one application for lower super output area, one application for primary care network area, and one for GP level. We've also got a user guide to cater for the non-technical user, and I'll quickly open that up to show you what that looks like. So the story map is really easy to navigate. You've got the ability to jump to different help sections from the navigation bar, which appears at the top of the screen. Each section contains a how-to on different elements that are within each application. So for example, you can read about how you would use the filtering functionality or how you would generate a print. As you can see, it's really easy to scroll through and read about how you do each of these different things. I won't dwell on this too much, and I'll move on to show you one of the applications. So let's get into it and have a look at the LSOA level application first of all. So when it loads up, you can see that we're greeted with a splash screen. This is showing key icons and other helpful information to help the user navigate the tool. We've also got links embedded within this splash screen to allow the user to access the other levels of geographic granularity that look at the bowel cancer screening project. So you can access that from this screen, but I'll press OK and that splash screen will disappear to reveal the web app underneath. The default view is set to be Brighton and Hove, and we're looking at a heat map visualization here of bowel screening uptake, where red represents areas of poor uptake and green shows areas of higher uptake. If I expand the legend, which is the icon housed in the top left-hand corner, I can see that anything below 60% is classed as low uptake, and anything above 80% is classed as high uptake. So other useful icons in this app include the ability to change base maps, and this allows the user to have a different experience viewing the map. We've also got the ability to print, so you can generate prints in different formats with pre-populated titles, and the ability to view metadata under the info icon included in the top left. Another really useful function of this web app is the ability to layer up multiple data sets on top of one another. Within the layer list here, you may be interested to assess uptake through a health inequalities lens, for example. So I'll put on the layer which is called Index of Multiple Deprivation by LSOA. Now, if I come across to the layer on the right, Screening Uptake, I can use the transparency slider to toggle between these two layers, and this enables me to see if areas of low uptake align with those areas that are showing as more deprived according to the Index of Multiple Deprivation. Similarly, if I wanted to look at uptake or positivity against ethnicity, for example, this is also presented at LSOA level, so I could do the same thing by toggling on and off the ethnicity layer. For demonstration purposes, I'll turn this layer off and we'll move on to look at the filters contained within the application. So on the right, you've got various filters which respond to different layers. There are two options here. We can either focus on uptake or we can look at positivity. The uptake layer responds to the uptake filters. And as you can see here, I've got lots of different things to choose from, including the ability to drill down by gender and also by age group. So I'll change male to look at all genders, and I'll change 60 to 64 to be all ages. You can also change the extent you're looking at. So I'll change the sub-ICB to be the whole of Sussex. And you'll see that each time I've specified a different thing from the filters, the map redraws to reflect the segment of the patient population specified. Now, at any point, you can click on an element on the map to see some more information, and this is presented in a pop-up window. So I can click on an LSOA, for example, and read about the uptake and positivity percentages and numbers within that area for the specified time period and patient population that we've configured through the filters on the right-hand side. So it's important to know that these pop-ups are dynamic and they'll change to reflect the active filters which are working on the map at the time. Now that we've seen all the information contained here, I'll close this window down and just point to the ability to see change over time. So at the moment, I'm looking at data from 2020 to 2022, but I've also got 2018 to 2020 data in here. So that redraws, and I'll change the remaining filters to look at males aged between 65 to 70, and maybe we'll focus on West Sussex only. I could also choose to focus on a specific uptake level using the uptake level filter at the bottom of the screen. So maybe I just want to see areas in West Sussex that have poor uptake. And then when I change the time period at the top to look at the same thing, but for 2020 to 2022, you can see I've got fewer red areas drawing on the map for the most recent time period. So this indicates an improvement in uptake across West Sussex within males aged between 65 to 70. Now, the PCN level dashboard, which is an aggregated version of this, takes this a step further to include a change over time layer, and this is visualized similarly through a heat map. So I'll just pop that on screen for you to have a look at very quickly. So if we look at the legend, you can see that we've got green areas showing PCNs, so primary care networks, with improved uptake, and orange areas showing those PCNs which saw reduced uptake. Again, I've got the option to configure the change over time layer against the change over time filters, selecting different segments of the population and watching the map redraw as I do so each time. Finally, I'll just touch quickly on the GP level application. Now, this is slightly different because it comes from Fingertips, so it's a different data source. We're presenting it at different geography, and also this app doesn't include positivity data. We're just looking at coverage and uptake. But again, I've got the ability to flip between those two things, and the map will redraw based on what I'm choosing from the filters on the right-hand side. So, for example, if I wanted to look at GP practices with very low uptake, it will redraw to show me GPs with low uptake. Or I could focus on GPs with a high level of uptake to get a good idea of which GPs are performing really well. And that will redraw again. Now, I appreciate that this is a really rapid run through of 3 different applications, but hopefully you can see how the bowel cancer screening tools at all 3 different geographies can work towards improving patient outcomes against bowel cancer by enabling the end user to quickly and easily identify specific areas and sub-cohorts of the ICB population that may be of concern, the ICB can target and promote effective patient engagement, which will ultimately work to improve the uptake of bowel cancer screening, catching more cases in the early stages. So I'll pass back to Adam for now, but happy to answer any questions at the end of the session.
Thanks, Josie. I think that demonstration does a great job in illustrating how this tool supports the NHS in understanding populations and integrated clinical data to identify spatial correlations at different geographies. The visualization impact enables the story to be told by clinical data and presents this in a digestible, intuitive, user-friendly, and of course engaging format. A key impact of this work is that it enables primary care networks, bowel screening hubs, cancer alliances, and other integrated care systems to use the same web tool, which helps them to engage with one another. The RGS system allows us to easily and seamlessly share the application with the right user at the right time. The tool provides evidence for relevant healthcare professionals, as well as local authorities, to help in targeting and promoting effective engagement to improve cancer screening uptake. Targeting is a key method through which the NHS can improve patient outcomes. The ability to drill down by population segment enables the identification of small-scale problem areas very quickly. We've seen from Josie's demo how substantial differences exist between males and female screening in different areas. With long-term plans aiming to reduce screening ages, the data from the tool reinforces the concerns being raised about current screening rates and can support conversations with the necessary parties on how best to target high-risk cohorts. The use of Esri technology has allowed us to quickly and easily develop solutions like this using out-of-the-box Esri applications within the ArcGIS system. So that's it from us. Thank you much for listening, and we'll hand over to Duncan for the next presentation.
Thank you, Adam and Josie. An extremely useful piece of work that I think clearly demonstrates the value of understanding your data through the lens of geography. I also think it's really clear to see how intuitive and this very visual application, it can really enable leaders of integrated care boards or anybody conducting population health management to make those focused decisions. And I do believe that the content that the guys from NHS South Central West, Adam and Josie, have demonstrated today, we can share those with you in our follow-on email. So look forward to that. So I'm now delighted to be handing over to Sally and Daniel from Digital Health and Care Wales, and they are going to present on their Health Map Wales application and how they are optimising spatial data at a national level. Sally, over to you. Oh, you're just on mute, Sally, actually.
Sorry. Right. So I'm Sally Cox. So thanks for inviting us here today. And I'm here today with Daniel Cullen, who's a colleague. We're both from Information Services at Digital Health and Care Wales, which is NHS Wales's national digital organisation. So we're going to talk to you about our public-facing interactive mapping tool, Health Maps Wales, and how this is being used and can be used within NHS Wales and Welsh Government to provide insight and improve how services are delivered. So how it can also aid planning by providing accessible, regularly updated data, and also promotes then evidence-based care. So I will start by covering some background, and then Dan's going to come in and provide a short demo, and then we will run through some of the use cases of how Health Maps Wales is being used within NHS Wales. So firstly, a bit of background. So Information Services within DHCW manages the All Wales Data Repository on behalf of NHS Wales. So we collect and process the facts and the figures that help NHS Wales run effectively. And this is all stored within the NHS Wales data warehouse in accordance with national standards and information governance policies. So the national data sets that we maintain include secondary care, births, deaths, child health, and many, many more. Collected data is then analysed and converted to useful information, data products, insights, which help health boards and Welsh Government to monitor, analyse, shape policy and manage and improve the care that patients receive. So Health Maps Wales is one of the few public-facing data products that we have within NHS Wales. It was a Welsh Government-sponsored project, and it was launched way back in 2009 with the aim to make nationally collected population-based data more readily available and accessible, and also to have the ability to compare this data across Wales. Health Maps Wales allows the user to explore Welsh health data by small areas, to map trends over time and to compare against local and national figures. Originally, Health Maps Wales was produced using GeoWise's Instant Atlas server and Ordnance Survey's raster backdrop mapping tiles. But however, as time went on and GeoWise became part of Esri, the site became unsupported. So back in 2021, with the assistance of Esri and GeoWise support staff, we migrated the platform from Instant Atlas server to Instant Atlas with ArcGIS Online, utilising Esri's mapping capabilities. So I'm now going to pass you over to Dan, who will explain a little bit more about Health Maps Wales and run through a short demo.
Thanks, Sally. I'm Dan, and I'll talk a bit more about Health Maps Wales and then give the demo. So Health Maps Wales is an interactive mapping tool for exploring Welsh health data. And the wealth of datasets held by DHCW results in Health Maps Wales having hundreds of health indicators covering 20 themed areas such as cancer, substance misuse, child health, and common procedures. And the health indicators are presented by various geographies, USOA, MSOA, LSOA, local health board, local authority in Wales. And most of those indicators include 10 years of previous data to allow users to view trends over time. Some indicators are also split by age and sex when numbers allow, and the data is all standardized to allow for robust comparisons between geographical areas. And from this, a complete picture of health in Wales can be assessed. Next slide, please, Sal. Thanks. So Health Maps Wales aims to allow simple visual analysis of complex health data across several Welsh Government programme areas, which in turn promotes collaborative working and identification of trends. Users can map trends over time and compare against local and national figures to easily identify health inequalities and support continuous improvement. And the data also contains comprehensive metadata with a full list of standard definitions and terminologies. Furthermore, all data can be readily exported for use in other reports. Next slide, please. Health Maps Wales provides many benefits. Bringing data together from different data sources provides a more complete picture of health, including the ability to look at the correlation of different factors such as deprivation. Health Maps Wales also benefits public health professionals by enabling them to identify inequalities, and furthermore, those same health professionals often wish to monitor the effectiveness of targeted work undertaken within health boards or other geographical areas, and Health Maps Wales' ability to compare areas makes that task easy. Information is also provided by Census AMPA area, which allows targeted planning and a better understanding of the situation in local areas. Additionally, since all the data is published publicly, external users such as academics and researchers can freely export the data behind Health Maps Wales for their own use. And we also monitor the usage using Google Analytics. And so, for example, in May of this year, we had 203 users. I'll now quickly share my screen and jump into a brief demonstration. Hopefully you can all see this. So there's several ways to view the data on the Health Maps Wales website, and a few of the most common data sets, such as the cancer one here, are actually available to view in dashboard format. The data tab in the top left, this allows you to view all the indicators available under the theme, as can be seen, and you can also change the year as needed. The geography can be changed in the top right using the drop-down menu, and as you can see at the moment, I've selected local health boards, and in particular an Iron Bevan University Health Board. You'll note that all Wales is always shown in the time series widget and the bar chart widgets on the side, and this allows for easy comparison to Wales. To view the other indicators on the website, you can either use the data menu here, or you can jump into the Data Explorer. And the indicators here can be searched, and when we click on and say all cancer death rates, you're immediately taken to the metadata page. Now, the metadata contains spatial and temporal information, as well as methodology and any clinical codes used to calculate the indicators. To view the data for the indicator table, that's the data tab at the top, and here you can change the geography again, but also filter on the time frame as well as the features, so in this case the local authority itself. You also know that the data can be easily downloaded, and these filters and drop-down menus carry through on all the tabs. So the map view just shows a thematic view of the data, and this allows users to quickly visually see changes across Wales between the different local authorities in this instance. And again, you can change the time period and features, but here you can also change the data classification. By default, quantile's chosen, but you could switch to natural breaks or extremes if you desired. And again, this map can be exported into a variety of file formats for people's own use. Time series. This tab shows changes across the years, so for all the available years for the indicator. Again, the same filters follow through, but here you could switch to a line, bar, or stack chart, depending on which the user prefers. And again, this chart's available to download to different file formats too. The last tab, ranked bar chart, this shows the values for each feature within that geography for the same year. So the differences between the local authorities for 2021 and the year in geography can be changed as well. This map can also be downloaded, and again, the filters can be changed. You'll also notice that on all the tabs, there were two buttons in the top right. The first one, download, that allows users to download all data available for that indicator as a zip file. And the second one will just copy a URL if the person wishes to share it with their colleague. Anyway, that concludes the demonstration. I'd like to pass you back to Sally to talk about evidence-based decisions.
Right, thanks, Dan. Thanks for the demo. So now we wanted to take you through some of the use cases where Health Maps Wales data and Esri mapping capability has been used to support evidence-based decisions within NHS Wales and Welsh Government. So the first example is the Cardiovascular Atlas of Variation, which was published in 2019 and focuses on three main cardiac conditions: acute coronary syndrome, heart failure, and atrial fibrillation. The Atlas was created as a collaborative project with multiple organisations in NHS Wales to identify unwarranted variation in key aspects of cardiac care and to investigate the reasons for this variation. So it aimed to raise questions about equity of access, effectiveness, and value of the services provided by NHS Wales. For the Atlas, maps were created for multiple indicators and geographical areas following a patient's journey from the community through primary and secondary care. So we utilised thematic maps here, clearly indicating where there was geographical variations in the care that the patients received. Maps and tables were created and exported for a published report, and interactive maps and indicators are published through Health Maps Wales. So the data used plus a link to the report is available on the Health Maps Wales website. This here just shows the Atlas indicators within Health Maps Wales, so you can have a look at those. So the next example illustrates specific use of Health Maps Wales in North Wales, where the public health team there used the available data to track the rate of tonsillectomies following evidence-based guidance. So the background there was that North Wales seemingly had higher rates of tonsillectomy intervention than elsewhere in Wales. And because of this, there was a drive to support clinicians and GPs to work more closely in line with the evidence base, and Health Maps Wales was used to monitor the progress of this work. More recently, we've used Esri's mapping capabilities in a Welsh modelling collaborative hackathon event where we looked at whether travel times to clinic for cystic fibrosis patients across Wales affected the attendance rate. So patients with cystic fibrosis often have to travel to clinic regularly for monitoring, and clinicians were interested in whether the distance that these patients travelled relates to non-attendance of clinic appointments, potentially leading to emergency admissions and poor outcomes. So this map shows DNAs, or did not attend, rates across Wales for a national cystic fibrosis clinic in Cardiff. So now I'm going to pass you back to Dan to take you through another use case before he will wrap up with some future developments. Thank you.
Thanks. So during a recent hackathon, the NHS Wales executive was interested in the impact new build developments have on nearby GP practices. And so through collaboration by colleagues across NHS Wales and with use of the OpenStreetMap API, new build development data was actually extracted from Swansea Council's local development plan. And then we utilised ArcGIS Pro to plot that development data on a map alongside pre-existing GP practice data. We've also recently acquired ArcGIS Pro extensions, including the network analyst and data interoperability tools. And those tools allow us to convert and utilise ordnance survey data to produce drive time service areas and matrices. And so we've actually produced nearest facility drive time maps for new build developments in Swansea. And that's what the map on the slide shows. Next slide, please. ArcGIS Pro has also aided in the decision making as to which areas would be best for the placement of a mobile diagnostic unit. So we created thematic maps at LSOA and GP cluster geography levels, and these maps contained admissions, mortality, and disease prevalence indicators for areas such as coronary heart disease, stroke, dementia, and cancer. And these were then used by our customer to assess which areas would benefit most from a mobile diagnostic unit. And ArcGIS Pro made it easy to export these maps and supply them to our customer in a PDF format, which they then went on to use in their own reports. Next slide, please. We've also started to contribute to Esri's Living Atlas. So Living Atlas is just a collection of publicly available, ready-to-use maps, apps, and data layers produced using ArcGIS. And so far, we've published feature services for rural and urban classification and general fertility rate. And we have plans to publish many more in the future as well. Next slide, please. We've also utilised some of Esri's other applications to publish health service locations on the Health Maps Wales website. So we've used story maps to create the latest series of our annual admitted patient care headline reports, and we're due to publish those in July. And we're always looking to add new indicators to the site too. So for example, in the most recent Health Maps Wales release, we added 2 new themes with indicators for diseases of the musculoskeletal system and life expectancy. Next slide, please. And furthermore, as I just mentioned, we've recently acquired the Network Analyst tool, and so we're intending to release drive time maps and matrices for health facilities across Wales, such as major emergency departments, GP practice locations, and pharmacies. And the map on the slide is an example of what we intend to produce, so it's showing areas with a 15 and 30-minute drive time of an emergency department at a Welsh hospital. Next slide, please. And we're always open to new feedback and suggestions, and we look forward to hearing your thoughts on what could be improved. Thanks.
So thank you, Sally and Daniel. And looking at how Digital Health and Care Wales are transforming their data to understand patterns and variations over space and time at a national scale, I think is really, really impressive. And equally to see the range of use cases and benefits that they are realising. So thank you very much for sharing that story with us all today. Finally, I'd like to hand over to Rob from NHS North East London Integrated Care Board, who is going to present on how they are using Esri technology to unlock hidden insights and drive new ways of working. Rob, over to you.
Hiya. Just testing you can hear me. Good.
Yeah,
okay.
Can hear you, Rob.
Right, great. Thank you to Duncan and Esri UK for the invitation. This is it's a great opportunity. I really appreciate it. And to the other presenters, great work. My presentation is not going to include too much interactivity, and it's perhaps more of a personal view based on experience over a few years, but using actual examples of work and things. So I'm Senior Insights Manager at NHS North East London, ICB, ICS, and I've worked in NHS information for 20 years at national, strategic and London-wide, and also now to more local areas, sort of commissioners, CCGs, commissioning support units. I've specialised in GIS since my MSc at Birkbeck in 2016. So this is sort of like 7 years of work, and everything I share today is not only from my current organisation because we're fairly new, but it's all pretty much my own work. So I'm quite proud of it. So what are we going to talk about? So NHS North East London, like the other ICBs areas I've worked with, is a highly complex area, and the real world is complex. So when we talk about our GIS spatial analysis, we are applying it to some real sort of knotty questions. For example, North East London has 2 million residents. It has 268 GP practices. It's got forecasts of a plus 300,000 or so extra residents over the next 20 years. And it's complex in the sense of patient flows, overlapping registered populations that you can see here, very high but uneven population growth, and access and proximity to services is very complex due to the varying urban density and the incredible level of transit options there are in London. So what do we do for our clients? Well, we do what you might expect, or hopefully some of you might expect, that we do for in terms of location intelligence. So we do a lot of fairly advanced spatial analytics, which is what I'm going to talk about a lot today. Interactive dashboards on occasion. We do travel time and accessibility analysis, and we've done some applications for national teams, national platforms, as well as locally. Now we're tool agnostic, so in the bottom right you can see we use all sorts of tools. Esri's been a cornerstone of a significant proportion of our work since we started, or since I started. We always try and champion geospatial analysis. It tends to be project based and answering particular questions, and it's more than just a map. We want to bring in academic research and pretty complex spatial techniques to actually answer real world questions. And eventually, and I'll talk about this at the end, we want to use high resolution patient location data to do some of the things that we've talked about. So today, a few things I'm going to talk about. So number one is looking at spatial relationships between health outcomes and social determinants. Now, the main ideas I want to talk about is that spatial data science enhances knowledge and understanding, and we need more detailed patient data. So rather than just provide context to a problem, I think we need to better direct attention and resources to the right places that most need them. Now, we know very well that the extent of deprivation is likely to correlate with worse health outcomes for a population. So this is a chart that was done for North East London a little while back, and it's avoidable mortality rate for those aged under 75. The left hand of the chart is more deprived end of the population, the right hand the least, and the notes, as the notes say, there's a difference with 2.5 times difference between the most deprived areas and the least deprived in terms of avoidable mortality rate for the under 75s. So how do we relate this and explain this by actual locations and direct resources to it? We can use fairly traditional methods. You know, people like heat maps, and we do use them a lot, but does this really tell us what we need to know and direct attention? There are questions about, is there variation from the norm? Are there statistical outliers? Is there significant evidence of clustering? Things like that. So I'll go into a bit more detail about that a bit later in the talk. So a heat map is useful, but does it really get to the nub of the question? Similarly, just talking about where deprivation is not necessarily the answer too, because sometimes deprived areas aren't as bad as what we think, and sometimes less deprived areas are worse than we think. So we need to have sort of ways of looking at the data. So what we try and do in our work is to take the underlying data and map it to certain geographies. Now we've been using MSOA quite a lot more than usual because MSOAs now have names. The House of Commons Library gave them names a few years ago. We've been using them a lot, and ONS use them a lot too. And it enhances the legibility of neighborhoods for the user, so they can actually name a place that they can recognize on a map. And we also combine data as well. So combine data with deprivation and the rates of health outcomes. We identify clusters by combining that data. So this is actually was an interactive tool based on our markdown. So we issued this to the people of the project team to sort of play around with the data. And eventually we can kind of come to a conclusion that there's a cluster of areas that demand resources are show a cluster of bad outcomes that we can name and we can do something about and start to plan how we apply resources to it. So an important question around this, and this is where we get into sort of GIS specialism or geospatial specialism, is that how can we be more confident that we've identified the right places as outliers? And I've got a quote here from an interesting paper recently that said that we need some more critical thinking about geospatial data because it's so prevalent nowadays, but there's the danger of failing to account for the geographical properties of data. And what does this mean? Well, this means that there are certain confounding aspects when you look at the way that things are spread on a map that you have to take into account of to actually know that you're looking at areas that are actually high or actually low. So there's a few things we try and do, or we like to try and do more of, to mitigate against that. So one of them is spatial smoothing. So where the boundaries are placed for particular geographies, or the scale of a geography affects the outcome, the actual rates that you measure. Now, one way around this is to actually use tools to spatially smooth it. It's a bit like a moving average in statistics. And you look at the nearest neighbours of a particular area. And what it allows you to do once you've applied it, it allows you to get slightly away from your traditional heat map, which is number 3 on the left here, and a bit more into recognizing true outliers, true low areas, and clusters of health outcomes that you might want to study further. So that's one thing, spatial smoothing. The underlying problem here is called the modifiable aerial unit problem. So please look that up. It's quite interesting if you don't know about it already. Another thing we try to do is look at, well, are how high or low outliers clustered or randomly spread? So there are certain measures you can use. Probably the most famous one is the local indicator of spatial autocorrelation, or Moran's eye. This has recently been used by ONS when they're exploring local income deprivation. And what this does, it gives you more confidence when you're looking at clusters that it's not just a random pattern across an area. There are truly statistically proven as far as the model goes, clusters of high or low areas that you can say, well, this backs it up as well. This backs up what we assume from the original map, is that these areas are ones we should be looking at. And then finally, in this section, this is a ArcGIS Pro tool, emerging hotspot analysis. So when you're looking at things over time, there is variation. So the charts in the top left of this slide show one area over time that has the same average over that time, but you can see that the orange lines change. So bottom left is getting better, perhaps. Bottom right is getting worse over time. The others are more or less the same. So how do we make sense of this without having to look at countless numerous maps and try to make sense of it without some sort of statistical or model underneath that really gives us the information up front? So this tool, emergent hotspot analysis, takes layers of time. It uses a spatial smoothing approach that I discussed earlier, and really kind of gives you a picture for the whole time. So this was that COPD rate in Newham over, I think it was 7 years or 6 years by the quarter. And what the tool enabled us to see was which areas were always consecutively high, which areas had like latter day worsening of conditions, more recent improvement of conditions. So it gives you an idea of a more firm thing to go on, that we're not just taking one slice of time, we're actually able to look at things over time and come up to some conclusions that where we want to direct our attention, where we want to direct our clinics and things, is on a good basis. Furthermore, we've done more work with councils before the local ICB ICS integrated care agenda, and this is kind of moving to what a phrase which is bandied around a lot about the hyperlocal. So the hyperlocal is about looking at neighbourhoods of data, neighbourhoods, the health conditions in neighbourhoods, environmental conditions, and can we fix things on more local data than looking at it more holistically across the whole area. It's a new phrase to me, but that's what I've read about it. So there's one link which I can't remember. Yeah, nhsproviders.org website. It's got a really good explanation of it. So the type of work we've done in this is where we had a project for Islington, where they had super zones around all their schools. So they wanted to study the 400-meter walk area around each school and evaluate it on certain things. So one was fast food outlets. They also looked at pollution, things like that. And what we did, and we're keen on this, is to bring academic research into the real world and actually apply it to real world questions. So we brought in a thing called Chalice, which I think started in Wales as a sort of, it was looking at alcohol related harms and said they were associated with change in alcohol outlet density. And this seems like a really good thing to look at for fast food outlets to say, well, if there's a cluster of outlets around the school, that's obviously worse than ones that are around the edge. So how do we do that? We use a thing called I can't remember the phrase actually. Yeah, I can't remember the phrase. But we use the Butterfield filter to actually score each zone around each school, and we were able to direct resources again about which schools have the most density of fast food outlets. And we also used a similar thing to looking at pollution levels, and we also used the same process for looking at access to open spaces in Newham as well. So we looked at postcodes here, weighted by numbers of addresses. We looked at the weighted density of access to the local open spaces, so we could come up with areas of Newham where we felt that there wasn't as much access to open spaces as others. So quite technical ways of doing stuff, quite technical GIS specialist ways of doing stuff, but it's really useful in the end because the output is useful to direct resources. So what can we do in the future? Well, high resolution patient location data linked to healthcare usage and outcomes. This is what we want to get to. We've experimented with some data sets, but we're not really allowed to use them in anger or put out actual output to anyone. And what this is based on is that we're currently sort of stuck with LSOA level resolution of data about our patients, where they live, and also how they use services. Now you can see in this display here the current resolution on the left-hand thing for that orange area. If we look at LSOA level, it comes down to 8 data points. So we measure travel time from that, or we measure things around that. It's kind of 8 data points. But if we had a more high resolution level of patient locations, and this one is to 100-meter grid coordinates, then we get 160 data locations, and then we can start to split that up by the types of people that live there, the types of theme that we're looking at, and apply it in relevant ways to study populations. It's been really good to hear that NHS England are starting to put unique property reference numbers to patient data. So this is very timely thinking this way, and hopefully in the future we can get access to this kind of data. So what do we use it for? Well, we had an experimental data set, which we used to look at providing context to our commissioners about actual distribution of patient locations that GP registered. So we made some tools for them to look at 50%, 75% and 90% contours of where the patients lived, and they were able to play with it, compare different PCNs or GPs, and get a sort of like a slightly more real-world view of where patients live. And it's much more complex, as you can see, in North East London than you might expect. GP catchments don't have much relation to do this. We've also used it for very detailed travel time analysis, reallocation of patients when practice closes. This is much better in terms of we can talk about convenience for actual patients and where they live rather than just LSOA level data. And we can also allocate people and patients more to what the local services have in terms of capacity. We can meet what the local picture is in terms of capacity and what each service is able to take, and allocate things on different walking times. So this is what the patient data gave us. But in the future, what we want to do is link it to, and this is the final bit, we want to link it to outcome data, hospital data as well, because one of the things in North East London is that we have huge housing developments. One of them is going to add 20,000 people to the local population. It's an irregular area. We can't really use LSOAs to measure that population, and isolate that population, but we need to monitor investments for that new development. So how do we do that? If we had more detailed information, we could really close in on that how that new estate is using services. Are our investments working? Do we need to change them in future, and do we need to change them for other areas? And this also feeds into segmentation. So the output would not necessarily be a map, but we'd be able to segment people on the basis of their proximity to services, what kind of environment they live in, and open space and things like that, but also people that live near A roads or particularly environmental problems. So that was a really quick run through. I hope you found it inspiring. These are my details, so happy to talk through at more length with anyone else that wants to talk about it. Thank you.
Thanks, Rob. Yeah, really novel approach, and I mean, as you saw, they're incredibly scientific and meticulous. Yeah, fascinating to see the range of approaches that you're taking and the different types of data that you're incorporating into your geospatial analysis. So thanks to all of our speakers, all truly inspiring examples which demonstrate the power of geospatial technologies and how they can transform our understanding of data and the world. So we are short on time, so I think maybe we could field one question. We have had a number of questions come in. So perhaps if I could just ask our speakers just to turn cameras on, and we'll just see which question is at the top of Slido, and see how we want to address that. Perhaps let me have a look what the question is. So the question at the top of Slido is, how easy is travel analysis to perform, and can public transport be included? Well, I think the good news on that question is we definitely saw examples of all of our speakers showing some level of transport travel time analysis. I guess just to start off before we go to the speakers, and perhaps we can just do a quick roundtable. Public transport analysis is entirely possible. So we do work with a partner called Travel Time, who have a plugin into our system, and they regularly update bus networks, train timetables. So that's all definitely possible within the Esri platform. Perhaps, Adam, Josie, from your perspective, there's a question about how easy is this to perform, and maybe we could just do a quick kind of roundtable to get your views and perspectives rather than kind of my views on that.
Yeah, happy to start off. We're a customer of Travel Time. We use them for travel analysis. Yeah, we do walking and cycling, as well as drive time, distance, but also, yes, as you say, public transport is possible. You can even do ferry as well if you want to as well. So how easy is it to do? It's a geospatial process, geospatial tool, so lots of parameters to watch out for, but generally a fairly easy geospatial process to run based on Ordnance Survey, OS highways, network data sets. So I would say it's only as good as your data set that you've got behind it, but yeah, lots of parameters, fairly easy to do when you know what you're doing.
Yeah, thanks, Adam. Completely agree. I don't know, Rob, Sally, or Dan, from your perspectives, if you've got kind of anything else to add to Adam's answer there. I know, Rob, I believe you also use Travel Time.
Yeah, I mean, there are open source alternatives as well, but I think the public transport thing is quite hard to get to without having to pay for something, a license. So there is an add-in into ArcGIS Pro, which is really like a game changer in terms of putting it straight into a GIS piece of software and using it straight away. There are other travel time things out there, but it's a growing phenomenon, and it's kind of underexplored. I think the relationship between how people use services and distance and things like that, and especially public transport and A&E. A lot of people in London go to A&E using public transport. So yeah. Yeah,
thanks, Rob. Sally, Dan, any really quick points? I'm just conscious of the time. I don't know if you've got anything else to add from your perspectives.
I think this is one for Dan.
I'd just echo the rest, really. It's quite simple to do. We've had a lot of support from Esri and the Ordnance Survey as well, since that's the data we've been using. I know that other colleagues across NHS Wales, particularly in the Welsh Modelling Collaborative, they're looking at travel times in terms of public transport. But for us, and in terms of Health Maps Wales, the priority really is publishing a national drive time data set for Wales. And that's kind of the aim at the moment.
Yeah, good stuff. Thanks, Dan. And there are other questions, but we are short on time, so I will liaise with the speakers, and we'll look to follow up with answers to those in our follow-on email. But just to kind of wrap up, so I just wanted to say thank you all for your time today. I hope that the session was informative, thought-provoking, and of course, it's inspired you all to consider the role of location intelligence within your organisations and the hidden value that's just waiting to be realised. Again, just like to emphasise my thanks, my huge thanks actually to all of our guest speakers, who I'm sure you will agree were excellent and demonstrated tangible benefits that they are delivering to their organisations through unlocking location intelligence. So as I've mentioned, so we'll share a recording of this webinar in our follow-up email. So do share this with any colleagues that were unable to make this today. And as mentioned, I will ensure that we follow up with the questions that we were unable to answer on Slido during this session. So on that note, thanks again all for your time today. If you do have any questions that pop up retrospectively, please do not hesitate to get in touch with myself or any of the speakers. And if you are new to the geospatial approach and location intelligence and you want to try this out for yourselves, please do not hesitate either to get in touch, because we would love to be a part of your journey. So thank you all for attending, and I hope that you enjoy the rest of your day. Thank you very much.